a great honor to introduce Lee Dellon, which probably, I think you are the greatest expert on pain in the world. So, and I saw referrals from everywhere. I think I introduce you, and you have to forgive me because I think I will need half an hour to introduce you in a good way, and I will be short, but please just add something if I forget something very important. Professor Lee Dellon graduated at Johns Hopkins University in 1966. And he is currently professor of plastic surgeon and professor of neurosurgery at the Johns Hopkins University School of Medicine. What I would like to stress up is that he received his PhD from the University of Utrecht. So he has a clear connection with the Netherlands. I think it's part of the honor we have to have him here and to let him present. Of course, Dr. Dellon's research interests center on neural regeneration in the basic research laboratory. His work included models for peripheral nerve compression, neuroma treatment, neural regeneration through absorbable conduit, and diabetic neuropathy. Dr. Dellon's clinical work is focused on computer-linked devices to measure sensibility, and we have the honor to have one here. So I feel very honored because I think we are the only one in Europe, so it's very special. Treatment strategies for pelvic and groin pain and treatment of a symptom of peripheral neuropathy related to nerve compression, whether due to diabetes, chemotherapy, or unknown causes. He has won 26 national research awards and more than that. He has had 77 visiting professorships, author of 8 books, 104 book chapters, more than 500 peer-reviewed journals, articles. 1 book on pain solution, in 2007, a second edition in 2011, a Chinese edition. His most recent book is Joint Innervation, published in 2019, and in Chinese in 2020. He has been on the editorial board of Plastic and Reconstructive Surgery and many other journals, and is a founding member of and past president of the American Society for Peripheral Nerve and vice president of American Society of Reconstructive Microsurgery. And of course, director of the Dellon Institute for Peripheral Nerve Surgery, with institutes in Baltimore, Maryland, Anderson, and Nevada. So again, forgive me for the short introduction. I hope I mentioned anyway everything that is really important, and I give you the floor, and thank you, Lee, to be here with us.
Thank you very much, Stephanie. Is my presentation up on the screen?
Yes, it is.
Okay, that's the first miracle. So you can see my screen and hear me?
Yes.
Okay.
Very well.
I enjoyed listening to Arno, Misha, and Luke. I won't repeat any of the things they said, although I have some slides that agree with them. Thank you for all your kind words. And do you still see a picture of me, or you don't see me, just my screen? But later when you see me, I'm wearing a tie that I got in Rotterdam. So I have a little bit of something.
Oh, that's good.
Okay. Yeah.
Yeah, we see you. We like your tie.
Yeah, it's from Rotterdam when I taught there at a meeting in 1986. So this is the book that you mentioned, and when I had the honor to speak for your group a few months ago, we spoke about joint pain. And today we're going to talk a little bit, as you've already heard, why nerves cause pain and how I treat injured nerves. And specific nerves will have some lower extremity nerves. And we talked about CRPS. We're going to talk a little bit about that. And maybe one day, if you ask me back, we'll talk about groin pain, migraines, and pelvic pain, because there isn't time today to talk about those. This paper by Dr. Rosen is truly amazing. It demonstrates. What I wanted to do is start with the diabetics. I have a 1-hour talk on diabetes, but this happened just May 18th. And you already mentioned Dr. Rosen. And I gave a 2-minute discussion of his paper that I wanted you to hear. In a randomized, controlled, sham-operated study that not at 1 year or 2 years, but at 10 years, there is significant improvement in this horrible, progressive, and irreversible disease. This study showed that subjectively, pain was significantly improved for the patients who had the surgery compared to sham controls, and significantly improved to those who had no surgery, who actually had no improvement in pain. And objectively, even electrodiagnostic studies, which traditionally progressively become worse over time, improved in those patients who had the actual operation, but not in those who had the sham operation. To put this in perspective, in 1987, I first presented the results of this type of surgery to our society. 4 separate laboratories demonstrated experimentally the basis for this surgery working. There have been 15 level 4 studies, but then 2 meta-analyses that showed that if a diabetic with neuropathy has a positive Tinel sign over the tarsal tunnel, they have an 80% chance of improved sensation, decreased pain, and prevention of ulceration and amputation. This is now the 3rd randomized control study that confirms this surgery. There have been 3 economic cost-benefit analyses, the last by the Hopkins School of Hygiene and Public Health, that show this surgery is cost-effective, improves quality of life, and improves longevity. I have 2 questions for Dr. Rosen. So I'd like to switch from that to actual injuries. And I'll show you a recent discovery of mine from the history of medicine. Ambroise Paré is usually credited with the Wounded Man photograph, but in fact, it was from Hans von Gersdorf, who was from Strasbourg. And he has this in his book, which has colorful illustrations. For example, the first real drawing of how to do an amputation the way he did it and take care of the wounds. I just thought I'd mention that to you because I only recently learned about this. But to go back to the basic parts, this man once came to see me. He'd had 53 previous operations. He'd only been injured between his thumb and index finger. And you see, he still has a nerve stimulator on, and he wants another operation for his pain. So amputation is not the answer for chronic pain. When I finished plastic surgery and hand surgery, and then began to do research, these were the questions that needed an evidence base for neuroma treatment. What to do with the end bulb neuroma? Should you resect or transpose it? Bill Littler, the famous hand surgeon in New York, said not to disturb it, but just move it to a new quiet place. Which nerve is really the source of pain? You see multiple nerves in this drawing here over the dorsal radial aspect of the hand. And we will know and show you in a minute that there should be 2 nerves that you must look at and try to understand whether one or both are the cause of the pain. And what should we do with the proximal end of the nerve? So we did this work in baboons. We took mature end bulb neuromas that we knew we could create, and with neurophysiologists did single unit nerve fiber recordings. This was published in 1985. You see Dr. McKinnon, Dr. Campbell was chief resident in neurosurgery when I was in plastic surgery. Raj and these 2 neurophysiologists. Raj then became chief of the anesthesia pain group at Johns Hopkins. But we found that there were spontaneously active pain signals going on in the end bulb neuroma, which was the experimental basis to prove you must resect the end bulb neuroma. Then what should we do with the proximal end? And as we all know, the dorsal root ganglion remains intact when the nerve is injured, and there's distal Wallerian degeneration, and we cannot change any of those things at the moment. But the only thing we can control is what to do with the proximal end of this nerve, because it will always sprout. And we had the hypothesis that if you took we can look down here for a minute. If you took denervated muscle and you put a motor nerve in it, it will innervate the motor end plates. If you took a denervated muscle and put a sensory nerve in it, it would innervate the Golgi tendon organs and the muscle spindles. But we had the idea that if we put an injured nerve into innervated muscle right here, nothing would happen. Just the way nothing happens if you put an injured nerve into a normal motor nerve. So we did this in monkeys before we did it in people, and we created proximal incisions, and we injured the radial sensory, palmar cutaneous, and dorsal ulnar. And then we had a group where we implanted the nerve into muscle and a group where we just cut it, which is what's most often done, and left it proximally. And in the groups that were left with a proximal cut, the nerve endings went up and re-innervated skin, which would cause recurrent pain. They innervated hair follicles, and they innervated, there were myofibroblasts that were created that would contract and send pain signals. But when the nerve was put in muscle, none of that happened. There was much less connective tissue when the nerve was placed in a muscle, and there were just little sprouts, and a classic end bulb neuroma did not form. And so this difference in connective tissue was very significant. And following that paper, we began to implant nerves into muscles in humans. So that's starting in 1986, we began to implant nerves into muscle. Ludwig Moskowitz in Vienna was the first. He had several patients that he put nerves in muscle, but he didn't do any type of experimental work, but he gets the credit for the first one to do this. And then starting in 1984, Alan was one of our neurologists at Hopkins, and he's at WashU now and still working there. He was my classmate in medical school. But since 1984 and 86, we've begun to put nerves in muscle. So when I finished hand surgery, this was the main difficult unanswered question. This is probably what Rodin's thinker was worrying about. How can we solve dorsal radial wrist pain? And Susan did her hand fellowship in Baltimore with Dr. Curtis and myself in 1981 to 82. And we found that there's not one nerve there, but two. In some people, for sure, there's two separate LABCs and radial sensory nerves, and they do not overlap. But in 94 specimens, 75% did overlap. So with an injury to the dorsal radial hand, you must consider that two separate nerves are involved. And the way to sort through this is to use nerve blocks. You already heard mentions of nerve blocks. When a nerve block is done, you have to inject something. The patient knows they had a nerve block. But then you say to them, did you get better? And they may say no, but that doesn't mean the nerve block didn't work. It may mean that the correct nerve was not blocked. So you have to inject them, then you must see that the desired skin territory goes numb. And then you have to ask them if they've had pain. That's the correct way to do a nerve block and know if it worked or didn't work. So first we will use some non-operative techniques for the first 6 months, but if their pain remains, and then they're in the chronic pain state with a neuroma, and the nerve block relieves their pain, it has a positive predictive value in my hands of about 90%. If the nerve block works, we'll then proceed to resect one or more nerves and implant them into muscle. So the mistake in the past was if someone has pain with the dorsal radial hand, they would inject them. They try to do the nerve block here. And you can see that would put both nerves to sleep. So we first have to block the LABC in the proximal forearm, and then we want to block the radial sensory nerve over where it exits beneath the brachioradialis as it inserts into the humerus. So you make a mistake if you inject where the pain actually is, if you know that more than one nerve goes to that location. In some people, the palmar cutaneous branch is also involved in that mechanism. So if you do these two blocks and they still have some pain, especially when you touch them, see if it's on the palmar side. And we'll make an incision up near the brachioradialis muscle. We'll find the LABC in the subcutaneous tissue near the vein. We'll find the radial sensory nerve deeper under the muscle, stimulate it first to be sure you're not working on a motor branch of the posterior interosseous nerve. We don't actually have to go down distally anymore. In the beginning we did till we had confidence we could find the nerves up here. If for some reason you can't find the nerves up here, you can always operate distally, pull on the nerve and find where it moves up in this area. And then we loosely put the nerve into the muscle. We don't use any stitches. And you have to implant them with the elbow straight so that the nerve is under maximal stretch, and you have to release the antebrachial fascia also along the LABC. And so you can do this, and we've reported this in 1987. You can see how long ago. It improves function and relieves pain. The most common operation probably done on the hand is for carpal tunnel syndrome, and we see all these people who still have incisional pain. This must be due to the palmar cutaneous branch of the median nerve, and I'll show you our approach to this. That's a painful scar. So in these people, you can touch them here and they'll have pain that will radiate into the thenar eminence and along this, but it won't go into their fingers. If you tap them and it goes into their fingers, they will need the median nerve to have a neurolysis in addition to resecting the palmar cutaneous branch of the median nerve, in which case they'll have recurrent carpal tunnel syndrome and a neuroma of the palmar cutaneous branch. And so I make a new incision, ulnar to the original incision. So the problem is that the median nerve may be very, very adherent to this first incision. And if you try to go through here, your blade may go directly into the median nerve. By making a more ulnar incision, you can avoid that problem. And then proximally, you'll find the palmar cutaneous branch under the fascia. And you can retract the tendons and the median nerve and just go directly down, and you can implant this nerve into the pronator quadratus muscle. And that was described by us in 1992. So in 1994, the American Association for Hand Surgery had a meeting, and I was on a panel to predict the future of hand surgery. And although I had a lot of unhappy people, I predicted that the hand surgeon will be doing foot surgery. And in that regard, I want to mention something that Stephania said about my PhD. The PhD that I got at Utrecht, when I went to defend my PhD thesis about decompressing nerves in diabetics, the three plastic surgeons, the neurologist, and the rehab specialist all thought that the work I presented was wonderful, but that meant decompressing nerves in feet. So I'd like to show you a little bit about feet. So here's a place where many people say they have pain. When they step down, they have pain. It goes right out between their third and fourth toe. You may know that the name for this is Morton's neuroma, but it really is not a true neuroma. Those patients had no injury at all. And so in 1992, I described this as a chronic nerve compression. And the treatment is not to resect the nerve, but to decompress the nerve. And the nerve becomes entrapped under the intermetatarsal ligament. And as it goes, the nerve rubs back and forth while walking. You get a swelling here. And on ultrasound and on MRI, it may look like a neuroma, but there's been no injury, so it can't be a true neuroma. It's chronic scarring built up around the digital nerve. And it's felt that this is the most common web space for it because it gets contributions from both the medial and lateral plantar nerves. So Morton's neuroma is not a neuroma, it's a nerve compression, an interdigital nerve compression. So we reported a small group of people where you could make an incision dorsally, release the ligament, and you will find this swelling that looks like a true neuroma. But the ligament used to be here, or it may have been here. And if you push on the bottom of the foot, this pops up, and it's chronic nerve compression, and you don't have to resect it. You see, we're going to try to protect the dorsal branches of the deep perineal nerve so they don't get pain on the top of their foot as a complication of you're trying to relieve the pain on the bottom of their foot. So you're really doing a neurolysis of the common plantar digital nerve through a dorsal approach. I thought I was the first to do this. It turned out this was described earlier by a doctor from France in 1979. And similar to what he did, we have this number of really good results. He had many more patients that he operated on than I did. But here's a 10-year follow-up. And we've written a paper where this nerve and its compression can occur in every one of the interspaces in the foot, even between the big toe and the second toe. They each have different names, but you can do the same operation in each web space. If you have to go into two web spaces, and some people have the problem in adjacent web spaces, instead of making two parallel incisions, we make an incision that comes down and branches over. And you can lift up this half as a page in a book and this half as a page in a book to get into each adjacent web space. And they heal very nicely. So if you resect the Morton's neuroma, what do you get? You get a true neuroma. And then when the patient comes to you with previous surgery, then your task is what to do for a true neuroma of a common plantar digital nerve. So for example, here's someone who's had two previous Morton's neuromas resected, and the plantar nerve retracts and comes right out into the metatarsal head where the person's walking and becomes very disabling recurrent pain. And I make an incision which is smaller now, but we make it in the non-weight bearing plantar surface of the foot. We no longer go way out here to find the neuromas. I'll show you what we do. But in the beginning, I had to do this to learn how to do a much better operation. The problem with cutting the nerve out here is, what do you do with the proximal ends of these nerves? They're still right where you're going to step down, and the small muscles in the foot are not large enough to absorb these nerves and protect them from pressure. We have to come back to where these nerves originate, which is in the medial and lateral plantar nerves. So I now make my incision just in this area right here. And if you go somewhat distal and elevate with your loops and with a fine micro scissors, you can find the divisions of these. And you can actually gently pull on the nerve and you'll see the correct toe move, so you can help identify the correct nerve. We're going to put them into the arch of the foot, deep to the quadratus muscle. So you have your flexor brevis and then the quadratus muscle, and deep to that is the actual arch of the foot. So we'll get back to this tarsal tunnel in a minute, but if you just focus here, you can retract these muscles, and then this nerve will go past the muscles. It'll be covered by two layers of muscle and be in the arch of the foot. And I'll show you a picture of that. We want to put the nerve into this area where there's just fibrous tissue. It then will be covered with two layers of muscle. In the beginning, I used a mini Mitec, and I stuffed that in and sutured the nerve to the end. Many of the people that have recurrent Morton's neuroma have tarsal tunnel syndrome. And in fact, in our group, we'll show you this paper from 2001, that it seems that once the tibial nerve is compressed here, once you've operated on the nerve out here, if the nerve is still compressed as you walk, you get symptoms of pain in the bottom of your foot that often can be misinterpreted as recurrent Morton's neuroma, when in fact it's really proximal tibial nerve. So in every patient going to surgery for recurrent plantar neuromas, you must check that they don't have a proximal tibial nerve compression. So in a series of patients, 75% of our recurrent Morton's neuromas patients, in fact, needed tarsal tunnel surgery. And this is our success rate operating on both the tarsal tunnel and the medial recurrent interdigital nerve. So if someone's already had this problem and they have a true neuroma in the bottom of their foot, then this is how we approach it. We make our incision in the non-weight bearing area. We draw out where we expect to find the nerves, and then we'll make this incision. Once you make the incision, you can retract the incision to the medial side, you can retract the flexor brevis muscle to the medial side or the lateral side, and so you can find the medial plantar nerve and identify its branches. You can retract it to the other side and find the lateral plantar nerve and its branches. With intraoperative electrical stimulation, you can be sure you don't hurt the important motor branch from the lateral plantar before you resect anything. Then you can resect the nerve and suture it to the mini Mitec. Now I don't do that anymore, but it was fun to do for a while. It takes extra time to do, but now I will just stick the nerve up into the fibrous tissue and leave it there without the mini Mitec, and it does very well. So here we find the lateral plantar nerve and the one contribution to the neuroma that was in the third and fourth web space, the medial plantar nerve and its contribution to the neuroma in the third and fourth web space, and we'll implant them each distally with the mini Mitex, which is fun for microsurgery, but you can just stick them up into the fibrous tissue. And once they're there, they'll be covered by the quadratus plantar and the flexor brevis. The first patient I ever had with this, I really didn't know what to do for him. He was a runner and a track star at the University of Maryland. Nobody wanted to operate on the bottom of his foot. So you see when this was in 1988, I made my incision and put his recurrent Morton's neuroma in a muscle. And he gave me his trophy when he ran his first 4-minute mile for the University of Maryland. So I decided this was going to be a good approach. It's technically quite difficult to do. Now, many of you know this ancient history in China where some of the royal family would have their foot bound and come up with this shape. And I'm sure these people had tarsal tunnel syndrome. And these people, they also have tarsal tunnel syndrome. But many, many people, more common with diabetic neuropathy and with injuries from ankle injuries, have tarsal tunnel syndrome. As Stephanie mentioned, you can identify this earlier than with electrical testing by doing neurosensory testing, but we discussed that the last time I talked to you all. But here's an example of the pressure specified sensory device being used to measure sensation. I actually didn't know about this syndrome. It was described by 2 orthopedic surgeons separately, one named Keck and one named Lamb, and they said the tarsal tunnel was the carpal tunnel. And when I got my first patient with this in 1980, sent to me by a vascular surgeon because the patient had normal circulation, I went to the cadaver lab and started thinking about this and realized that the tarsal tunnel syndrome is not the carpal tunnel. The tarsal tunnel is not the carpal tunnel. If you put your own hand up and look at it and compare it to your foot, the tarsal tunnel is really the distal human forearm. And if we tried to fix carpal tunnel syndrome by dividing only the antebrachial fascia, no one would get better. And in fact, most people doing what the orthopedic surgeons did had very low success rate. And therefore, they are in our society and need to have repeat tarsal tunnel surgery, releasing what I will show you are 4 medial ankle tunnels, not just one. Look at all these papers related to tarsal tunnel syndrome. And you can see some very, very low success rates. And if you look, besides not releasing 4 tunnels, they immobilize the patient post-op. We know from hand surgery, you want a nerve that has had neurolysis to be able to glide and slide, maybe a soft cast or dressing for the first week, but then the fingers are always moving, the elbow's always moving. So when I designed my operation for the 4 medial ankle tunnels, I'll show you what we do for their rehabilitation. Tarsal tunnel syndrome has the same symptoms as carpal tunnel syndrome, but it occurs in all the feet, the bottom of the foot, and the heel is equivalent to the thenar eminence. I'll just say that again because we're going to come to what to do for heel pain, and it's not always releasing the plantar fascia. So the tarsal tunnel is right here. That's the human forearm. Here's the thenar eminence. The big toe is out here. There's going to be a medial plantar and a lateral plantar tunnel. And so if you do this cross section, you will see in the hand, these would be the thenar muscles. This would be the transverse carpal ligament. This would be the carpal tunnel. This would be Guillaume's canal. But in the foot, these are the abductor muscles for the big toe. And we found a separate medial plantar tunnel, a separate lateral plantar tunnel. And for those of you who did hand surgery, if this were the hand, this would be the hook process of the hamate. And people that have a non-union of the hook process have an operation where we remove the hook and make one large tunnel for the medial, median, and ulnar nerve. So I designed an operation where we're going to cut through here, cut through here, cut through here, and we will remove the septum, making one large tunnel in the foot. So these are the tunnels, 4 medial ankle tunnels. So I call it tarsal tunnels syndrome. And here's an example of the release. Tibial nerve, the medial and lateral plantar nerve, and the medial nerve released in its medial plantar tunnel. The lateral plantar nerve and its release in the lateral plantar tunnel. And then we'll find the separate calcaneal nerve, and we'll talk more about the calcaneal nerve in a little bit. So here's my drawing. And in this drawing, we release the tarsal tunnel. Even though the pressure is really not there, I'll show you the references in a minute, but you can put a catheter in here and flex the ankle, and the pressure doesn't go up. We open this to identify variations in the calcaneal nerve and in the origin of the medial and lateral plantar nerve, and to gain access to these tunnels at the foot level. Then we'll retract this muscle. Here the muscle's retracted. And we'll release the roof of the medial plantar, the roof of the lateral plantar tunnel. And then we'll go across the septum to divide it. And you can remove that T-shaped piece to create one large tunnel, as is shown here. And then we'll come proximal along what would have been the roof of the lateral plantar tunnel to find the calcaneal tunnels. I want to show you this little nerve being retracted. This isn't in any anatomy book. My fellows call it the NOD, the nerve of Dellon. It's a branch from the medial plantar. It's almost always there. And you have to identify it while you're retracting these muscles and protect it, or they'll wind up with pain in this part of their foot. And we'll show you more about that in a minute. So in 2008, we reported 87 tarsal tunnel releases, and these were our results where the patient walks immediately after surgery. This incision goes very far distal, and it doesn't come up into here where the medial plantar tunnel is. And it doesn't come far enough proximally. So there's all kinds of wrong incisions that have been made when they come to you with failed tarsal tunnel. Now, the other speakers spoke about the saphenous nerve, but mainly the infrapatellar branch. And in the hand, we showed you that if you have a painful carpal tunnel incision, it's the palmar-cutaneous branch of the median nerve. We're going to show you that in the foot, if the tarsal tunnel syndrome is painful, it's a distal branch of the saphenous nerve. It has a posterior branch, which I'll show you. And if after surgery, the patient has pain in their heel that's worse, then they're going to have a calcaneal neuroma. And these are our papers in which we describe these. You can see this is already 20 years ago. So we get patients with all kinds of incisions, with pain in the incision. Maybe they do or don't have numbness in their heel, so you know the calcaneal branch has been cut. Again, we can do nerve blocks. So the saphenous nerve, the distal saphenous nerve, is next to the vein. And if the incision is painful, you can tap around and find a little Tinel sign and block them way up here, and the incision won't be painful anymore. If they hurt over here, you have to do a nerve block over here to find that it's the calcaneal nerve. So the sensory territories are a big help to you to know which nerve has to be blocked. And then the patient will touch the area without having pain anymore, and you'll know which nerve you have to remove. So here's an example, a 32-year-old woman who's had a tarsal tunnel a while ago. She had wound healing problems and an infection. And this surgery can be very difficult because the scar can be adherent to the nerve. And technically, you may want to take a small elevator, a freer elevator, go into the nerve, put it under the epineurium, and cut the epineurium. Here you see the fascia overlying here's the abductor muscle. The fascia that overlies it has been cut. The muscle gets retracted. And this is the roof, this white fascia. This is the roof of the medial and the lateral plantar tunnel. Coming across here is going to be the nerve from the medial plantar that's never shown in a book. Here's a calcaneal nerve. Here's the medial and lateral plantar nerves. So you take out the septum, and then you can get your finger to go right into the bottom of the foot. And you know that you've done a complete neurolysis. I don't wrap these nerves. It's probably because I can't sing, but I am not a rapper. You can laugh, that's a joke. But I find that if we do a neurolysis and the patient walks immediately, the nerve can glide, and we don't need to wrap a nerve. So I don't wrap a nerve, with my apologies to all the companies that make nerve wraps. We put a huge bulky dressing on. This was the type described by Robert Jones, an orthopedic surgeon in the United Kingdom a long time ago. We put on a sterile dressing first, then we take bulky cotton and wrap it over the sterile dressing with additional cling, and the patient walks. We make them march. They walk by lifting their knee, then their ankle won't bend. In trauma, the patient has feeling in the skin of the ankle, but the diabetic will not have feeling very often, and we don't want them to tear their stitches. This dressing permits about 10 or 15 degrees of ankle movement. The toes can move freely. And if you lift up from your knee, they can walk with a walker right from the recovery room. They won't tear their stitches. And they can walk up steps by going sideways. There's the bandage. So there are very few papers on the success of recurrent tarsal tunnel syndrome, but this is really good for recurrent nerve surgery. So you want to do 4 tunnels, resect painful neuromas, and do immediate mobilization. And in 2 separate papers, one in cadavers and then one in living people in the operating room, we put WIC catheters for pressure monitors in the medial and lateral plantar tunnels. And we show that the pressures are very elevated and that you can't get them down to 0 unless you remove the septum. Now, running is a big activity today, and many people will have heel pain. I don't know how many of you remember Latin, but if you mention heel pain, the first thing every doctor says is you have plantar fasciitis. Plantar fasciitis is post-static dyskinesia. That means the first time you put your foot on the ground after being asleep, first the foot rests, you put your foot down, the plantar fascia stretches, and you get heel pain. Many of the people, this is the critical question. If they get out of bed and their foot hurts and it gets better as they walk, they have plantar fasciitis. And we can talk about the treatment for that later if you wish. If they get out of bed and don't have pain and their pain gets worse, they have compression of the calcaneal nerve and they need the neurolysis that I'll show you. After having done this for many years, we actually published a paper on 85 dissections in patients when I use tourniquets. And every single pattern you can imagine for the origin of a calcaneal nerve. This is just one medial calcaneal nerve, and there's 5 different patterns. Many people have 2 calcaneal nerves. Here's the one I showed you. And there are all these variations to have 2 separate calcaneal nerves. And some people have 3 calcaneal nerves. And of course, somebody was going to have 4. And this is the point about opening the tarsal tunnel. Look for more than 1 calcaneal nerve. So we'll do our tarsal tunnel incision, and following the roof of the lateral plantar tunnel, coming this way, you can identify the calcaneal nerve, and usually the tip of a fine pointed instrument like a cryle will not pass along the nerve, and you know that they're tight there. And then you can do these releases very carefully, not cutting little branches, and you'll see compression and narrowing, thinning, where you can see through the nerve, where the nerve to the heel has been dying. Here's somebody who has that branch I was telling you, the nerve from the medial plantar coming in. And here's the traditional calcaneal nerve, which can come from the lateral plantar or the tibial. Look, this person has 3. And then you have to go very gently and cut the fascia overlying them and not slide your scissors all the way down, or you may divide a branch from this. Here again is the technique where you put the end of the scissors in. You can see the narrowing in the nerve after releasing the fascia over the top of the nerve. And then the scissors will slide down and you'll be able to feel the calcaneus, keeping the points together so you don't hurt the nerve. And you'll see where the nerve was compressed, giving them heel pain. So sometimes there'll be a true neuroma of the calcaneal nerve. And here it is. What are we going to do with this nerve? We're going to resect it. Here's the heel. I'm leaving the live end distal to the ankle joint is going to cause pain every time the foot's dorsiflexed. We must take the nerve proximal to the joint. And what's the most distal muscle belly? It's the flexor hallucis longus. Here's the muscle belly of the flexor hallucis longus. We're going to take the calcaneal nerve and implant it into the flexor hallucis longus muscle by just taking a clamp and dunking it in there. And there's the nerve in the muscle. And that's the treatment. And then the patient can walk immediately after surgery, and moving the ankle will not pull that nerve out of the muscle. So again, you want to do nerve blocks. They can have non-operative treatment first. Of course, you can put steroids in the incision if you wish. Then we're going to resect the neuroma, which makes the pain stop. We're going to put the nerve into a proximal muscle. What about pain over the top of the foot? Oftentimes, you'll see patients after they've had work on a bunion or a fusion. And this is like selling real estate. Location, location, location. So the deep perineal nerve, you know, is there already from a little bit of our talk by Arnaud. Superficial perineal nerve, which we're going to talk more about also, as Dr. Arnaud and Misha both discussed. And the saphenous nerve. In 1 out of 4 people, the saphenous nerve will go this far distally. 1 out of 4. So if someone has pain here, you have to decide if their bunion incision hurts, you have to block the deep perineal nerve proximal to the ankle next to the, so you know that the long toe extensor is here and the posterior tibial tendon is here. So you have them lift up their toe, feel the long toe extensor, feel the ankle extensor, inject between them, and you'll go down and block the deep perineal nerve proximal to the ankle. You do not want to inject here because they're 3 separate nerves. Superficial perineal nerve you'll block in the side of the leg. Saphenous nerve you can block farther up in the leg. And so you see how long ago we started doing this. There's a patient with all these previous operations, black and white photographs. They had complex regional pain syndrome. They've also had a proximal sympathectomy. And you all know Oscar Osmond. He spent 3 years working with me in Baltimore. He became like one of my sons. And here's a paper that we wrote. You see how long ago that was. So we want to cut these nerves proximal to the ankle, and we're going to place them into the anterior and lateral compartments. Here's another one for injured and operated on in 1987. 1990, they cut out the deep perineal nerve and left the end of it here. They had a sympathectomy, which wasn't successful. So we know this nerve is involved from our nerve blocks. We're going to operate on the nerve proximal. So I want you to notice this little tiny yellow line, which nobody ever notices. This is a posterior branch of the distal saphenous nerve, and this is the nerve that innervates the tarsal tunnel incision, just like the palmar cutaneous branch innervates the carpal tunnel incision. And this nerve is really shown here, but we never pay any attention to it. So I came up with this approach. For those doing microsurgery, you're coming directly down to get to the anterior tibial vessels. But I have to take care of the superficial perineal nerve in most of these patients. And so I devised an operation where I'll make an incision here over the leg. And as you heard from Arnaud, how many variabilities there are, I'm going to show you that we know the number from 2 different papers we published, 1 out of 4. 1 out of 4. So you have to believe everyone you operate on may have one of these branches of the superficial perineal nerve be in the anterior compartment. So we teach now to open the lateral compartment, identify the nerve, open the anterior compartment, and look to see if there's another branch. And we're going to divide this septum and cut it out, because when we're going to move this nerve into this muscle, to bury it in this muscle, we don't want it to find a new point of compression right here. So we're going to do the work on the superficial perineal nerve, then come across on the interosseous membrane and elevate these muscles, and we're going to find the deep perineal nerve. Your retractor comes over, it hits the tibia, you just pull up on your retractor and you'll find these. And then you can do it all through one incision laterally, and I'll show you that. So again, the books all show this, but 1 out of 4 people will have another branch in the anterior compartment. And so in a group of people with these neuromas in the lower extremity, this is what we did. I'll show you in black and white to show how long ago. So here is the deep perineal nerve being placed into the extensor longus muscle. And here's the superficial perineal nerve. You see, if you don't cut back the septum, you can create a problem where with time and wound healing, the superficial perineal nerve, not because it's a recurrent neuroma, but will become compressed against the septum. And the patient will again have pain over the top of their foot. And I have many of my own patients, I had to go back and resect this much more proximally. So this photograph is a good lesson of how you can fail. And so we've had very good success with this approach for pain over the top of the foot. Now, this is the papers. I thought we were the first again to identify that there are more than one branch. But in fact, here's an earlier paper from 1991 done by some of our military surgeons published in the Journal of Bone and Joint Surgery. Here's another paper in 1997. And we ourselves have two different papers, one on cadavers and one on living patients. And here's where the nerve is supposed to be. And these are people who have branches in both compartments. And these are people who only have a branch in the anterior compartment. You open the lateral compartment and won't even find a nerve. So you must open both compartments. And here's some examples. I want to show you from the front, you can see a swelling here. You can run your finger up and figure out where the nerve is coming through the fascia. And they will have a distally radiating Tinel sign here. And I have one patient that had a so-called lipoma resected, where fat was protruding with the nerve and they cut the superficial perineal nerve. But here's someone where their septum would be here, and here's two branches. And here's another patient with two branches. And sometimes one branch will be subcutaneous. And I think as Dr. Arnaud showed with his ultrasound, they can have a very high proximal exit through the fascia. There's another one. And here's a patient who has pain on the top of their foot after having had intradigital nerve decompressions and the nerve resected. But they resected the deep perineal nerve and leave it right there. So the foot is down here. We're going to work on the superficial perineal nerves. And then we're going to go across we're going to lift up on the muscles, go across on the interosseous membrane and find the deep perineal nerve and implant that also into a muscle. And here's another. Now, this is a variation that's important with the sural nerve. I don't know how many of you know this. Here's the superficial perineal nerve. Very often, and this number is not known, but it might be 80% of people, there's a posterior branch and it'll join the sural nerve. So if you have someone where the orthopedic surgeons have operated and they've injured the sural nerve and you do your nerve block here and their pain goes away, and you resect the sural nerve in the popliteal fossa and they still have pain and you wonder what's going on. It's because there's another branch joining. So with sural pain, you must consider that there may be a contributing branch from the superficial perineal nerve, and you may have to do a proximal nerve block. I don't know if you've ever heard of Joplin's neuroma, but in 1973, Joplin was president of the Foot and Ankle Society, and at their very first meeting, he described in the Journal of Bone and Joint Surgery a neuroma of the nerve to the medial side of the big toe. When the incision is made here to do the bunion resection, they will often injure this nerve. And again, you can come over here and find the neuroma and resect it, but what are you going to do with the live end of this nerve? So you can make a counter incision and you can pull on it and you'll know you've identified the correct nerve. And then again, you can go deeply and implant it into the arch of the foot. You can pull the nerve through. It may have some branches on the side to cut. You can pull it through and then implant it deep to the muscles into the arch of the foot. I want to talk just quite quickly about RSD, which Luke did a good job of discussing. It used to be called RSD, which in my book I call really stupid diagnosis. And I call it that not because it doesn't exist, but because the pain can be traced either to nerves that are entrapped, nerves that have neuromas, or nerves that are joint innervators. So I like to show this because this concept of causality was described in the American Civil War, where they didn't use bullets like this. They used little round musket balls, and they would partially injure many nerves. And patients had this horrible pain from partial nerve injuries. And he discussed the word causalgia, which then became RSD1, and then there was RSD2, and then in 1985, by Sten, what changed it to CRPS, which I just say is a bunch of crap. So you had this mentioned to you already, that in health we have normal perception of pain. That's acute pain, and it's due to tissue injury. And yes, there are all these other psychological components to it. It's a normal response, and it's what the nerve's doing. I went too fast. But if the pain persists, we go from acute pain to chronic pain, and that's where neuropathic pain comes in, and there's central mechanisms for this. And this is a pathologic state, and this is where we're taking out these painful neuromas. I want to bring you right up to date, and this is from Lancet earlier this year. They're going to discuss a different concept, and they're going to call it nociplastic. And it doesn't take any time. These are people who are born with this central condition, and it's a condition that has been called central sensitization. And it explains a lot of what we see clinically. And I'm going to go through this in a little more detail. And I thought, yes, here's the reference. Look, this is from Lancet just a few months ago. So this is very recently an international study, 4 different countries coming together to say, maybe we need a new kind of name for this problem, where there's really a patient who has decreased inhibition at the time they're born, 0 months. And then when they get injured and this mechanism starts, it's happening in a person who already has some central problem, and they're going to process pain in a very different way. So in fact, epidemiologically, these are the groups that are found to have this. And this is our CRPS group. But we find the same kind of problem underlying migraines, irritable bowel syndrome, interstitial cystitis, which is bladder pain, and this unusual problem. And one of the other speakers mentioned fatigue. So I never really thought this was, of course, I left out a B. I'm sorry, there should be a B there. This whole group of chronic pain is best understood in this context of people who are born with this problem. And if we operate on them, I'll show you the special anesthetic techniques we're using to help manage them. So this is from a paper I wrote a long time ago. And my hypothesis was that if pain can be due to a single nerve and cause causalgia, maybe CRPS 1 is due to pain from more than one nerve. And if we can treat one nerve, we ought to be able to treat this by identifying multiple nerves that are involved. And towards that end, I had 100 consecutive patients sent to me with CRPS. And by doing non-painful sensory testing, a Tinel sign, and a nerve block, we were able to identify 70 of those patients we thought had multiple peripheral nerve problems. This was quite a long time ago. And you'll see their age range and how long they had suffered with this problem. On average, 4 years or more. Very few did we get really early on. And this is my follow-up. We have many patients followed for 2 years or more and published them separately as described. And as you know, all kinds of causes for this can occur. But in the upper extremity, we had to combine neurolysis. Some patients required a joint denervation. Some required a neuroma resection. Some required more than these. And so here's an example of someone who's had previous surgery for the deep perineal nerve, previous tarsal tunnel surgery by another surgeon, and had CRPS. You can see the foot's a slightly different color. And we have to go ahead blocking the tibial nerve, blocking the saphenous nerve, blocking the deep perineal nerve, all in different locations, superficial perineal nerve. And then we have to see how they function and walk. Following a nerve block, this person with crippling and disabling complex regional pain syndrome can walk. And so in the upper extremity, pretty much every nerve can be involved, and you have to know the anatomy, as was pointed out, to identify these. And I think Luke showed many examples of upper extremity CRPS. I'm going to show you some lower extremity ones. And if they're swollen, we can't operate on them. And this is a technique we've used. We put in an epidural and they stay overnight in the hospital, and you can get the swelling down, and then you can operate on these very difficult feet. And again, a wide range of nerves can be operated upon. And here's just an example. And here are the references I showed to you before. And here again is the operation to identify all these nerves. And here's the saphenous vein would be underneath. And we're working on a painful tarsal tunnel incision. We find the saphenous nerve, it can have one or two branches. Far enough distal, they're usually all posterior to the vein. More proximal, there's a branch anterior and posterior. And you want to disconnect them. What muscle is here? We want to open the fascia and implant them into the soleus muscle. The saphenous nerve gets implanted into the soleus muscle. Superficial perineal nerve we talked on before. We block the nerve before we cut it so the brain doesn't experience pain. It's sort of a preventive type of anesthesia. Post-op, we use water walking. You all know lots of rehab for the hand. This is the best way for lower extremity. Patient just has to walk in the water, and the water rubbing on the skin helps desensitize the brain to what's going on. And here are results in this really, really difficult group of patients. And we can achieve in the lower extremity very similar results in the upper extremity. CRPS has never been reported to be, except for accompanying carpal tunnel syndrome. So this is the first report of anybody surgically operating on these people and following them. Here's a young boy back playing baseball as a pitcher. That's the operated foot with this pressure on it. Here's a lady who you heard them, they come to you in wheelchairs, and we had to operate on her lower extremity. And of course, you know what this is going to show. So this is our paper that has the 2-year follow-ups on the patients. And here's a 5-year follow-up. This was the lady you saw with the big swelling in her foot. Here she is, 5-year follow-up. And here she is walking without a wheelchair and without a cane.
I'm walking without crutches for the first time in 5 years.
Really? Okay, let's see you take a few steps.
How about that?
She actually recently ran a 3K race, which I told her not to do. So this is our term. We can talk about it, but it's called central sensitization, not sensitization. And it's an underlying condition in the central nervous system. There's a decrease in inhibitory pathways from the cortex to the dorsal horn. You have increased transmission of pain impulses. So I like to use this little cartoon that I created. Normally we have a large amount of inhibitory impulses. So when we get a pain impulse and it comes through from the skin and comes into the dorsal horn, it gets diminished by the inhibitory impulses, and just a small pain message gets up into the central cortex to be understood. What if we have a very small amount of inhibitory forces, which we believe is what happens in central sensitization? Then when the pain message comes into the dorsal horn, it doesn't get diminished very much, and a much larger pain message reaches the central nervous system to be appreciated. We don't really know where this deficiency in inhibition comes from. It's thought to come from these areas, but this is the basic model that pain comes in through the first nerve, and neurotransmitters, which are butyrate, get released. And there's a calcium channel that regulates this. And they reach the postsynaptic membrane, which is the NMDA receptor, where they set off a second neuron response that goes across the cord into the central nervous system. And the inhibitory response comes down here in the form of norepinephrine. So there's the glutamate going across to hit the NMDA receptor. And there's the norepinephrine that's coming down. And what can we do pharmacologically to help our patients to decrease the amount of glutamate released, to increase the threshold of the NMDA receptor so it doesn't respond to anything that comes across? So I'll show you this in this cartoon. We're going to give them gabapentin prior to surgery, and it's going to block the calcium channel so that the glutamate doesn't get released. But if there is some around, we're also going to give ketamine. And ketamine is going to change the postsynaptic membrane receptor, not acting on the central nervous system, acting here at the postsynaptic membrane. And so the message never gets through to the brain. Ian Carroll is at Stanford, and you may know Catherine Curtin, also at Stanford, but a hand surgeon. And he was funded by NIH to come up with evidence-based work in animals that prevent acute pain from becoming chronic pain. And these are the evidence that has been found in animals. And so this is our cocktail. If we have a patient with CRPS and we're going to operate on them, and we know they have decreased inhibitory response, this is the message. And you can look this up, and if any of you want to, you can email me and I'll send you this reference so you can read about it. But this is what we give our patients now. And I recently had a back fusion, and I had it done at Stanford, and I made sure they gave me all these things. And so in conclusion, we can identify peripheral nerve sites of painful input. We can do a neurolysis if we think there's a compression. We can resect a nerve and implant it into muscle if we have a cutaneous neuroma. We can denervate joints, and hand surgery principles can be applied to the lower extremity. I'm going to end my talk, and I think we have some time for questions. Thank you very much.
Thank you, Lee. That's great. We recorded this and we will send it to you. That's so many informations, and as I always said, you can do things and you can do things good, but there is a big difference in the way to do and above all in the results. So it's a good example, like thinking about a tarsal tunnel release, and you think you are doing a tarsal tunnel release, and actually you are just doing something, but not what you are saying that you are doing. So it's great. You mentioned the double-blind randomized study for the tarsal tunnel. I don't have a question about that, but I want to thank you because you was the inspiring person teaching me that if you want to in a scientific way to demonstrate something, you have to do in that way. That's why we are doing a double-blind randomized study on breast sensibility. So just thank you for you. I think there is space for questions. I think I see Renee with hand on. Renee is our chief of the department. You already met him. Hi, Renee.
Yeah. Hi, everybody.
Renee.
Hi, Lee. First of all, I would like to thank all the speakers because I think I have pain now everywhere after because I feel everything now after all your talks. And I also heard that sporting is not very good. I'm doing a preparation for triathlon right at the moment, so I have tarsal tunnel, I think, and Morton's neuralgia and everything. But I have a question for you. I think I completely agree with that Morton's neuralgia is not it's not a neuroma. But I was wondering, and it's when do you start doing surgery? Because I didn't hear anything about conservative therapy and restoring the transverse arch in the forefoot. And what is the moment you start thinking about that? Because we are normally used to do that, to try to do something about that, or would you go early in treatment and do surgery in an earlier phase?
And thank you for your question. In my first slide on nerve block, the second line was we wait 6 months. So 6 months is the simple answer to your question. But what actually happens in the real world is patients never find me till they've had their pain for 1 or 2 years and they've seen 10 doctors. So it's usually not a problem by the time they get to me. They've already had lots of the rehabilitation that Dr. Luke mentioned. They've had physiotherapy, they've had cortisone injections, they've had an attempts at hydrodissection, And surgery should be the last thing a patient has for pain. They have to try everything else first, all the neuropathic pain medications. And so 6 months, you know, if it's a patient I've operated on myself, we give them 6 months. By the time patients get to me, it's often, as you saw in the CRPS patients, they've suffered for 4 years, some of them 10 years. Mm-hmm. So from a practical point, as a surgeon, by the time a patient, today in the world, they all get sent to pain management, and they try the nerve blocks and injections and hydrodissections and drugs. And then very sadly, they try the spinal cord stimulators. So almost everything has been tried before they get to me. If I can prove by a nerve block it works, I don't think a patient should really ever have a spinal cord stimulator. If we can treat them by directly operating on the true source of their pain.
I think that's a very good addition, because I think I completely agree. Patients come to you after having done everything. So for residents also, it's important to realize that you only see third, fourth, or fifth line of treatment, and that there's. But sometimes what you say is also important. Sometimes we do some relatively easy treatment, and then we should start earlier, because what you said, stimulation maybe is not, should maybe go a little bit further behind in the treatment options, and that's why it's important to think about other treatment options too. So thank you again. Yeah.
Yes. I want to say about the tarsal tunnel. Receiving the PhD at Utrecht was very important for many reasons. When I was in the defense of my PhD, the first person to ask me a question was the chief of general surgery. And he said, it was very funny. He said, Dr. Dellon, when I received your CV, I thought you were looking to take over my job or provost of the university. I didn't understand you wanted a PhD. Why did you want a PhD? And I said to him that he was exactly right. But the work I did on diabetics, the basic work in rats, in the United States, if you are already in clinical practice, you cannot go back and get a PhD. But that I felt that the 6 years of basic science work I did in the animal models was worthy of a PhD. And what came from that, what came from Moshe Cohn accepting to sponsor me for a PhD, was once there was uniformity of opinion in the 3 plastic surgeons, the neurologist, the rehabilitation specialist, then his next resident who wanted a PhD began the first randomized controlled study ever. And that came from Utrecht. And now another one is being done with a larger number. And then the second randomized control study came from Canada. And the one I showed you was the third one from in the United States, where they actually did sham operations. They just cut the skin and sewed it back up and compared the patient to the operated side. So I think the answers finally all, I'm done. There's some remaining education problems. How do we get this information to medical students so the diabetologists and the internists know when a diabetic person with pain in their feet is seen, they don't just give them neuropathic pain medicine and give them special chews and check their blood sugar and put them on special diets. They need to examine them for a Hoffman-Tunnel sign, because if that Hoffman-Tunnel sign is present, we can prevent ulcers, amputations, falls with broken wrists and hips by restoring sensation to the feet. So as educators, my biggest problem is I don't want them to think I'm looking for patients. How do we get information down to the medical student level so they can learn in medical school that there is an operation to help these patients? So maybe as a chief of your department, you can have some influence in the educational process with the medical students so they may learn this.
Yeah, yeah, that's a good addition, because we tried also, and it takes a long way to convince, for instance, vascular surgeons. And we have this team, diabetic foot team, and we send them your articles already not so long after your defense of your thesis. But I think you should be earlier in the phase by medical students, educating them and showing them the results.
Okay, so with regard to vascular surgeons, this is really good that you work with them because they're a surgeon. They know you can operate on a diabetic foot and the foot will not die. So what I tell people when they want to start is you go to the vascular surgeon and you say, the patient is coming to you with neuropathic symptoms and you do your blood flow tests. If the vascular studies are abnormal, of course you work on the blood vessels. But what do you do to the 80% of your patients, 75% that have normal studies? Please just tap over the tarsal tunnel. If they tingle, send them to us, the surgical part of your diabetic wound care team. Because if circulation's okay, they may have a nerve compression and we could help them. So you work with the vascular surgeon, he can start sending you the patients.
Thank you.
Do you have any more questions for me, Stefania?
Yeah, I have a lot of questions. We need another session with you. I have the idea that every time you speak, I just get more questions than answers.
I would really like to talk about pelvic pain. I didn't know that your anatomist and your interventional pain person were going to talk about pelvic pain. I've spent the last 10 years on pelvic pain, and we've published many articles on this. And the approach that the surgeons take in France, always operating through the buttock, is really wrong for most patients. And I'd like an opportunity to show you why. Most of these patients have been injured in the front. And you can just think of the most common problem, which is a woman who has a baby and has an episiotomy where the baby's head tears the vagina. And then they have pain. The surgeon sews them up, the gynecologist, and 3 months later they come back with pain in their vagina. So, if it's a hand, I showed you, if it's the dorsal radial hand, every surgeon is going to know there's a cutaneous nerve. But for some reason, when a gynecologist sutures the vagina and the woman has pain, they can't make the mental leap to think maybe the perineal branch of the pudendal nerve is stuck in my scar. And I'll show you our approach. And so that, yes, you can block the nerve posteriorly and maybe relieve their pain, but the nerve is injured adjacent to the vagina, and cutting the sacral tuberous ligament is never going to help that patient because the injury was in the front. And it's the same thing for bicycle riders and men and women. And the same thing for men who are injured in the gymnasium and tear a ligament between their legs, which releasing the sacral tuberous ligament is never going to help them because that's not where the nerve is hurt. It's hurt anteriorly. And the 3T MRIs can't show the small nerves that far anteriorly. So that would be fun to talk to you about.
Yes, we will invite urologists and gynecologists for one evening. I think that's very interesting. I have also maybe a question for Misha. Misha, are you still there?
He's already gone. He's gone for supper and his first drink for the night.
Or maybe Lieke, you can also. What do you think about the role of fat grafting as a kind of? You already said you don't like wrapping, so I suppose you don't like fat grafting too, or do you have a different opinion about that?
Okay, I'll give you my opinion about that. The first paper ever given about wrapping was given around 1982 at the American Society for Surgery of the Hand. The format for the meeting was a paper would be presented and then someone would be chosen a month ahead to read the paper and discuss the paper, which is a very good model. So from the University of Alabama in Birmingham, a woman hand surgeon named Victoria Mazer presented wrapping of the median nerve for failed carpal tunnel. And back then they only had umbilical vein. And she presented an operation where she opened the incision, she did a neurolysis, she wrapped the nerve with the umbilical vein, she allowed early movement of the fingers. And then she claimed that the success of her surgery was from wrapping the nerve. And my discussion was that I open the skin, do a neurolysis, let the fingers move, and get excellent results without wrapping the nerve. And they never published that paper. And so I still am actually very happy with doing the neurolysis first, and know where the nerve is adherent that I've released it. I don't mind if people try to do a fat graft first. I don't know if there'll ever be any proof that something made by the stem cells is what's separating the nerve from the scar tissue. And if the patient, it may be that injecting fat between the nerve and the skin is doing the same thing as hydrodissection and has nothing to do with the stem cells or some miraculous chemical that's released. This is different than injecting in the breast and seeing a scar soften, or a scar that has changes from radiation therapy. I know there have been many reports of that changing, but it isn't clear at all that injecting fat around a scarred nerve is it's maybe safer than an operation, but it may require multiple times, and the needle may in fact inject the nerve and injure the nerve. So I'm not opposed to someone trying fat grafting first. If it doesn't work, we can operate on them. I'm just not sure what the mechanism is that we can attribute to fat grafting, whether it's just the pressure of the fat mechanically separating the scar or not.
Okay, thank you.
Leah, a resident of us has a question for you from a patient that just admitted at this moment. Can we ask your opinion about that?
Yes,
Hello.
Go ahead. What's the question?
Excuse me. Professor Dellon, thank you for your talk. I just thought about a case that we currently is admitted at our hospital. It's a young boy, a 17-year-old, who had a major trauma to his left leg, who developed a compartment syndrome of his lower leg, and the anterior loggia is completely removed, but the deep dorsal loggia is okay, and we know the tibial nerve is also intact on the MRI scan. There was nothing wrong with that, but the boy has no sensibility in his the sole of his foot. He can also not use the muscles that are stimulated by the tibial nerve, but he has pain in his heel. And how could you?
What can you tell me the mechanism of injury? What was his injury?
Well, he was driving a scooter, and it was a scooter versus the floor of the road. He had a femur fracture, an open femur fracture that was firstly solved with a fixator externa, and he also has a fracture of his tibia plateau and a fracture of his distal bilateral bimalleolar fracture. And it was firstly all fixed with a fixator externa, and now he has a pen in his femur. I don't think there's really any...
He has a what?
He now has a pen in his intermedullary pen in his femur.
Oh, and okay, you presented that very well. How did they diagnose compartment syndrome?
Well, actually, the first thing that they noticed was the open femur fracture, so there was a lot of attention to that. And then 24 hours, they did a secondary survey, and then they made also x-rays of his lower leg, and he developed tension, and then they found that there was a compartment syndrome at the second Luke operation.
But I mean, did they put a pressure catheter in the compartment and show the pressure went over 30?
No.
No, they didn't do compartment pressure measurements, right?
No.
Okay.
They didn't.
So, first, I'll tell you about some research I did. When I was still a plastic surgery resident, I began to use tuning forks. That usually we measure for hearing, or you put them on the ankle to measure posterior column function. And I reported, I think, 1980, the use of tuning forks to identify nerve compression. And the tuning forks are very helpful in the emergency room and in this kind of trauma situation. And you can still try it on this patient. You have a tuning fork. And what happened is, the tuning fork, you may remember from if you touch the tuning fork, it's a wave. We think the median nerve is cut on the wrist. and you say, do you feel the tuning fork? And they say yes, but they're feeling it through the radial sensory nerve over the back. But if you say, do you feel it in this thumb, and you compare it to the other thumb, they'll say we have decreased perception. Decreased perception is the same as having the nerve completely cut, because we took those people to the operating room and reported that. And so then the question came to me, can we use the tuning fork to identify compartment syndrome? And we took monkeys, monkeys, and we put them in a little chair, and you can picture the hair on the top of the monkey's foot, right? They have hair on the top of their feet. So we made a little device like a golf club, and it would go back and forth and just touch the hairs and move the hairs. And the monkeys were trained that when they could identify that the hair was being touched, they pushed a little wheel and they got apple juice to drink, and they were very happy little monkeys. And we wanted them to tell whether it was a high amplitude or a low amplitude. That's the same as the tuning fork feels loud or the tuning fork feels very soft. That's a difference in amplitude. My voice is low, my voice is high. That's a difference in amplitude of the stimulation. So the monkeys got where they could correctly identify that 95% of the time. They had a behavioral trainer with them. And then I put the catheter in the anterolateral compartment of their leg and filled up their leg with normal saline and measured the compartment pressures. And when we got above 30 millimeters of mercury, the animals could no longer distinguish what was moving the hair on the top of their foot. That means you can go down to your patient in the operating, wherever he is in the hospital room, take the tuning fork, touch the bottom of the foot. Don't touch the big toe, but touch the bottom of the foot, because that vibration may not get to the top of the foot. If you touch the big toe, you're going to stimulate the perineal and the tibial. But touch the bottom of the foot, touch the heel, and compare it to the other side. And if they say it's decreased, you'll know there is pressure on the posterior tibial nerve. And touch the top of the foot where you already think there's compartment syndrome. Okay, so first I'm going to stop talking to see if you have any questions about how a tuning fork can identify compartment syndrome. Okay, did the patient already have the anterior and lateral compartment released?
Yeah, and it was actually there was so much necrosis that the anterior compartment is gone, and that of the lateral compartment, only the perineus brevis is still there. Okay. So potentially the perineal nerve is gone.
Okay, so after compartment releases, I get some patients who complain of pain over the dorsal aspect of their foot. What do you think happened to them as a complication of the neurolysis that would let them still complain that the top of their foot hurts after complete compartment release?
Neuroma of the perineal nerve?
Right. So, God bless the orthopedic surgeons, but they're very happy to make these big fascial releases, in the process of which they often will injure the superficial perineal nerve. So it isn't failure of the compartment release. It's just a nerve injury for the top of the foot, okay? Okay, the bottom of the foot, the plantar aspect of the foot. And this is very important because I don't know if anybody knows about this. Okay, I have to just relax for a minute. Okay, excuse me. In the top of the carpal tunnel, failed carpal tunnel may not be failed carpal tunnel. What's the proximal site of compression on the median nerve? Pronator syndrome, right? They can have proximal median nerve compression. That's pronator syndrome. It may give them the same symptoms. It'll affect a different muscle because the big toe flexor, anterior interosseous nerve syndrome will give you problems with flexing your thumb and the long flexor to the index finger. Whereas carpal tunnel syndrome will give you thenar muscle wasting, okay? So in the foot, the tarsal tunnel, there should be no problem with bending the toes, and especially not bending the big toe at the IP joint, right? Right. So in the foot, in the leg, behind the popliteal fossa, is the soleal sling, S-O-L-E-A-L. And everybody knows that behind that is the popliteal artery and vein, but also is the tibial nerve. And my partner, Eric Williams, and I described in a cadaver study and then in humans, proximal tibial nerve compression. And it is the same as, it can give you similar symptoms to posterior compartment syndrome. You said there was not a posterior compartment, and I don't know why you believe that's true. And the nerve would still be.
They removed the.
Yeah. Go ahead.
They removed even muscle in the some necrotic muscles in the posterior compartment.
Okay. So when we're done, take a tuning fork and test the heel and the plantar surface of the foot compared to the other foot, and then ask the patient to bend the big toe, and you'll probably find they can't bend the big toe. And if they can bend it a little bit, you'll probably be able to break the force. It'll have only 4 out of 5 or 4+ out of 5. That'll tell you that they're compressed behind their calf. You can take your fingers and push behind the calf about 8 centimeters below the popliteal fossa. That's where the soleal sling is, and they'll probably jump. And the MRI would show the tibial nerve intact, but they probably didn't go behind the knee because of the metal from the orthopedic surgery. And since there was a tibial plateau fracture, the soleal sling comes from the tibia, and blood might have gone into this exact place to cause the compression of the proximal tibial nerve.
So what we have to do?
Then you make an incision behind the popliteal fossa. I'll send you our clinical paper. I'll send it to you when we're done. I'll send it to Stefania. And then you make an incision that goes from the popliteal fossa and medial along the calf. And you just pull the medial gastroc back as if you're doing a gastroc flap. And you'll see the soleal sling. And you clear off some of the soleus muscle. And you'll see the popliteal vein and the tibial nerve next to it. And you take a blunt, big clamp, like a tonsillar clamp with a blunt tip so you don't put a hole in the popliteal vein. And you can slide it under the sling and lift it away from the vessels, and then divide the sling, and you decompress the nerve. And they'll stop complaining probably about their heel. But the heel, remember, you have a bimalleolar fracture. So the patient might also have swelling and a calcaneal nerve entrapment distally. Okay, so this patient may have both a proximal tibial compression and a tibial nerve compression in the tarsal tunnel. And the MRI could be directed at the ankle. And the ultrasound even, you know, you have ultrasound people, it'll show that the diameter, the cross-sectional diameter of the tibial nerve on one side is greater diameter than the one on the other side. I don't know if they can reach the tibial nerve of the soleal sling, but they can reach it in the tarsal tunnel.
Oh wow, that's great. So I think it's a very good tip. We will do that. I will report to you what we find and what we will do.
Yeah.
Thank you so much.
Yeah, if I can get an airplane, I can maybe be there to scrub in on the case with you in about 12 hours.
You know, I think it's the next step. I hope Renee is online, but we want to have you in person here. At least the next time.
Okay, so I'll send you the reprints so you'll understand what to do for that patient. And try the tuning fork and let me know. You can write a case report because no one has ever used the tuning fork to identify a nerve compression in the leg and report it. I've used them only in the hand and reported it. So that'll be fun for you to see.
Okay.
Yeah.
That's what we do. That's what we do.
Yeah, and I agree with Stefania when COVID and everything is a little bit stabilized. The next step will be inviting you and we collect some cases.
Okay. Goodbye and thank you very much.
Thanks again.
Thank you. Thank you so much. There is a little present from Maastricht coming your direction. I have to send it to the Baltimore address or where?
Send it to Baltimore.
Okay, so I think I have the address, but I will check again.
Yeah.
Thank you to all speakers and thank you to all the residents and students organizing that. It's really inspiring, and if you agree anyway, we will organize also just an overview for the pelvic region and probably the breast region. But well, we will have a look, and we will try to have to figure out if it's possible to have you here somehow.
Okay.
So.
Bye. Thank you very much. And I enjoyed the other speakers
Bye.
too. Bye.
Bye.
Bye.